Thank you all for tuning in. I'm happy to discuss my experience with polymer-based endografts and specifically the ALTO endograft in one of my cases. Here is a 82-year-old Caucasian male presenting with an incidental finding of a 6.2 centimeter infrarenal abdominal aortic aneurysm. I'll let the axial CT images play while I discuss this a little bit further, but you can see the renals and ultimately a bubbling out of the right lateral wall of the infrarenal aorta, ultimately the 6.2 centimeters. Patient has a history of paroxysmal atrial fibrillation on anticoagulation, has active COPD, not on home oxygen, but on inhalers multiple times a day, hypertension, hyperlipidemia, and continues to be an active smoker. I'll just play this axial cut one more time so we can discuss it. As you can see, we're coming down. The abdomen, ultimately evidence of the celiac, SMA. The renals are almost equal, the left is a little lower. And then again, bubbling out of the aneurysm to the right lateral wall and enlarging in the distal aspect of the infrarenal aorta, at which point there is a bifurcation. Seems quite long, actually, for an aneurysm. We'll discuss the pre-case planning. To the screen left, you can see a infrarenal neck of approximately 10 millimeters, which essentially excludes a lot of other endografts that require 15 millimeter infrarenal seal and fixation. To the middle part of the screen, you can see again where we were concerned primarily for obtaining our seal. And that's something very important with polymer-based technology where fixation and seal are separated from one another. The most important part with the ALTO endograft is the IR7 or infrarenal 7 position, which is 7 millimeters below the renal where you obtain that seal. Again, fixation is obtained with the suprarenal stent, that's 3.5 centimeters. To the lower part of the screen, again, you can see the maximal diameter of the infrarenal aortic aneurysm at approximately 6.2 centimeters. And to the screen right, ultimately our case plan. 34 millimeter O-ring, which is the largest of the 5 sizes currently available for polymer-based technology with endologics. We ended up using two limbs to the left side because it was quite long to the left hypogastricardia, and I wanted to ensure I got enough and adequate coverage to ensure no type 1B endo leak or concerns for aneurysmal degeneration distally. It's longer than the 160 millimeter maximal length noted on these limbs, and so therefore 2 limbs were necessary to achieve that goal. The NX procedure is performed in the standard fashion. I do all my cases with PVAR technique, ultrasound guided access of the common femoral arteries in a retrograde fashion, ultimately upsizing to appropriately sized sheaths, obtain my aortogram, identify my renal arteries, which I think is important to mag up as necessary, which you can see to the screen right, to identify the lowest renal artery. Again, we specifically focus on placement of the infrarenal 7 position where we obtain our seal. And you can see the wires are crossing with themselves, so we plan on a ballerina-type crossover technique for contralateral gate cannulation. If you look closely, you can see, in fact, that the limbs are offset, which I think is excellent, allows for easier cannulation with the contralateral limb being 5 millimeters longer, and so it's easier to be able to cannulate that and not worry about cannulating the ipsilateral gate. Again, to the screen right, you can see really at the level of the at the left renal artery, with excellent seal at that level. At 4-month follow-up, again, you can see to the screen left a coronal image which is kind of sliced right through, and you can see the rings themselves, and you can see the suprarenal stent quite well positioned at the level of the left renal artery, which was slightly lower. This adaptive sealing technology is important because even if there's calcium there or thrombus, you can use that as part of your seal zone to ensure no type 1A endo leak. Importantly as well, on follow-up imaging, a lot of people get a little worried because you see basically a disassociation between the suprarenal stent and the iliac limbs. That doesn't mean there's no seal there. That just means that the polymer is there, and it takes some time to be able to see that. To the middle part of the screen, again, looking at the adaptive sealing zone, you can see what the polymer ring looks like at 4 months. It becomes less radiopaque than it was initially, and that continues to be the case as time passes by. Maximum aneurysm diameter can at 4 months just a little bit smaller as we would expect, and I expect that to continue to get smaller as time passes by. And it's the average that's taken with this type of computer programming, so a little bit smaller. And finally, to the screen right, that's what it looks like in MIP imaging. A lot of people get concerned because they don't see anything between the suprarenal stents and the bilateral iliac stents. Again, that doesn't mean that there is no fabric there. There is fabric there with a sealing ring. but it looks like that on post-operative imaging, so just keep that in mind when you look at that. Very happy with the use of the device. Don't have to worry about access. Treats just about any aneurysm, being on label with a 7mm infrarenal neck indication. Don't have to worry about migration due to the suprarenal stents to be able to get excellent fixation. So again, separating seal and fixation allows a small profile, allows us to treat multiple different aneurysms on label, and I'm very happy with it. And if anybody ever has questions or concerns or wants me to look at any case or I could help in any way, please let me know. They know how to get a hold of me. I really appreciate all your attention and be in touch if I could be of any help. Thank you so much.